From the JAMA Network, this is JAMA Cardiology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA Cardiology.
Welcome to the JAMA Cardiology Author Interviews podcast. I'm your host, Dr. Sadiya Khan, an Associate Professor of Medicine and Preventive Medicine at Northwestern University Feinberg School of Medicine, and an Associate Editor at JAMA Cardiology. It's my honor and privilege to host our guest today, Dr. John Ostrominski, a Cardiology and Obesity Medicine Fellow at Brigham and Women's, and Dr. Muthiah Vaduganathan, a cardiologist at Brigham and Women's. Today, we're going to be discussing their recent original investigation, Prevalence and Overlap of Cardiorenal Metabolic Conditions in U.S. Adults, 1999 to 2020. It's a little bit of a mouthful, but John, can you tell me a little bit about why you wanted to put these three things together, cardio, renal, and metabolic?
Absolutely. Again, thank you so much for having us on this platform. Very exciting to discuss this further. And so in essence, it's really well established that cardiorenal and metabolic conditions, so namely cardiovascular disease, chronic kidney disease, and type 2 diabetes, are individually prevalent conditions that were really responsible for substantial morbidity and mortality, not only in the U.S. population, but globally. However, although these conditions often arise due to shared or sequential pathways of disease onset and progression, really less is known about the frequency with which these conditions overlap in the same patient. And so, because clinical outcomes are often worse among patients with overlapping CRM conditions, but also because we now have unique therapeutic opportunities at specific intersections, we wanted to further characterize the extent of this contemporary CRM overlap in the U.S. population.
So, as you mentioned, it's not surprising that this is common because we know that these risk factors cluster together. So, Muthiah, what made you guys want to quantify this more concretely?
From a clinical perspective, we often see these patients who are at the intersections of cardiorenal metabolism. And so I think quantifying this burden, understanding their treatment patterns, their clinical approaches to care is of vital importance from a health infrastructure perspective, because how we actually approach these intersections are going to become increasingly important as we move forward and as this CRM or cardiorenal metabolism becomes much more prevalent at a population level.
And some of the issue is that these conditions are intersecting from a pathophysiologic standpoint as well, that we see that metabolic disease is associated with both kidney disease and cardiovascular disease, and perhaps treatments need to approach it in that same way.
No, precisely. And thankfully, we've seen the recent developments in medical therapies and in certain senses also interventions and surgeries that simultaneously actually may benefit multiple disease pathways. And so you may find that a cardiologist may be using a therapy that may benefit the endocrine system or the kidney system. You might find an endocrinologist managing heart failure or a kidney doctor managing diabetes care in patients with advanced kidney disease. So I think we are seeing this in that these therapies simultaneously work on those core pathophysiological mechanisms.
And ultimately, with the goal to really prevent progression of metabolic disease, kidney disease, and cardiovascular disease. So if we look a little bit at the data that you used, John, can you tell us a little bit about this data source and your primary findings?
Absolutely. So we essentially leveraged nationally representative data from the United States. Specifically, we utilized the National Health and Nutrition Examination Survey, which is a cross-sectional cohort study that's been conducted for the past couple of decades. And so we kind of had two components for the analysis. One was a cross-sectional component leveraging data from 2015 to 2020, looking at really contemporary rates of intersecting CRM conditions. But we also looked all the way back to 1999 to highlight what the temporal trends and the evolution of these intersections might be. And so, focusing on the first of those two components, what we found was that taking the entire population, the entire eligible population together, over 1 in 4 patients had any cardiorenal or metabolic condition, with essentially nearly 1 in 10 having multiple CRM conditions. As one would imagine, when we focused on those individuals who were 65 years or older, the prevalence of intersecting conditions substantially increased. And among that cohort, we found that nearly 1 in 4 patients had intersecting CRN conditions.
Now, that's a really interesting finding, especially given the aging population. And we know with increasing lifetime risk of particularly heart failure, which is the comorbidity that I think of most when I think of the cardiovascular manifestation of cardiorenal metabolic syndrome. How do you think these findings in that older population, Muthu, help you as you think about where we need to be focusing our clinical trial efforts?
Yeah, it's a great question. And I think in terms of clinical trials, often in any individual disease state, we often apply fairly stringent exclusion criteria to exclude patients on, for instance, with uncontrolled metabolic disease or with severe forms of chronic kidney disease in cardiovascular trials. And I think that as we see this evolving epidemiology, we really need to take a more holistic approach, including in clinical trial design. And so trials specifically addressing these intersections, I think, are going to need to be performed and may even follow the pivotal trials that might be in more general populations to expand our understanding to these higher risk populations.
The other thing I'm struck by as we think about clinical trial design is historically severe obesity was often excluded from clinical trials. Many of our atrial fibrillation trials excluded the disease that is associated with some of the highest risk for patients developing atrial fibrillation and again, heart failure. How do we start thinking about broadening those types of enrollment criteria and emphasizing the importance of having a diverse and representative sample?
The first comment you make about historical exclusion of severe obesity, I think, is one that's extraordinarily well taken. We know that obesity itself, or excess adiposity or dysfunctional adiposity, is such a tremendous contributor to overall risk, especially cardiorenal risk, and it additionally also modifies outcomes thereafter. And in some cases, we've additionally seen that, especially in the heart failure population, that the established therapies additionally may be more effective for some aspects of the total spectrum of care, including well defined patient reported outcomes. And so I feel as though, as we're beginning to see, especially in the context of established ASCVD, with trials that have really attacked this specific intersection of obesity and ASCVD, that akin to other therapies that have attacked the CKD, type 2 diabetes intersection, evolving weight centric approaches to the management of diabetes itself, we may begin to see more weight centric approaches specifically to other cardiovascular or cardiorenal conditions. And clinical trials, I think, will be the foundation for this.
And I think while we've always had this concern that higher class obesity may confound our understanding of the underlying disease process, perhaps misdiagnose patients, for instance, with heart failure who in fact have symptoms attributable to obesity, I think we're seeing that, in fact, these overlaps exist much more strongly, and that once we get to a severe obese phenotype, we actually see that heart failure symptoms, atrial fibrillation symptoms can actually be intrinsic to the actual disease process. And those patients should be studied, should be understood to a greater degree.
And don't you think actually the converse often happens where we underdiagnose heart failure rather than this concern that we may be overdiagnosing symptoms that are attributable to deconditioning or excess adiposity?
Yeah, it's a wonderful question. And I think that that's absolutely right. We know as a community that many of our instruments may actually underdiagnose these conditions when applied in the severe obese ranges. Natriuretic peptides are the perfect example of that, in which we may miss a substantial group of patients who may have clinically overt heart failure. And so this issue, I think, is becoming increasingly important in the United States as we conduct clinical trials. But actually, worldwide, as obesity burden continues to increase, I think even in globally conducted trials, we really need to relax these metabolic exclusion parameters that have traditionally excluded this large, unmet, and at risk population.
So, overall, very striking findings, right? More than 1 in 4 had some type of cardiorenal metabolic condition. And in fact, it seems like it's only getting worse. Definitely disproportionately affects individuals who self identify as non Hispanic Black, who are socioeconomically disadvantaged. Where do we go from here, John? How do we use this data to move forward in our clinical practice?
In reflecting on these results, I've thought about really three major domains. And I think the first of which is, again, kind of broadening our focus, not only get to kind of a disease specific approach, but rather an inclusive focus on underlying root causes and pathophysiologic antecedents. I think on the basis of our recent discussion about excess adiposity, certainly that is a root cause for so many patients, but also other things that we regularly see in our common practice, things like hypertension, dyslipidemia, or even prediabetes, these being key opportunities to take an inclusive perspective and then additionally intervene aggressively on those conditions to prevent subsequent multimorbidity. One additional important domain, I think, would be novel training pathways, and specifically around these CRM conditions, thinking about endocrinologists being actively engaged in the care of CKD, of cardiologists being actively engaged in the care of diabetes. And I feel as though this diverse spectrum of clinicians that care for this high risk patient population is a really important one to provide education around. And then finally, from the perspective of healthcare service design, to really develop systems that systematically identify and target high quality care for this high risk population with patients with multiple CRM conditions. And as one example of the systems that have been well deployed, these are multidisciplinary integrative clinic level approaches that really cater to these intersections.
You make a great point about training, but also this need for interdisciplinary care. And oftentimes we are all operating in our own clinical silos within our specialties and even within cardiology, within our subspecialties. And so, how do we really enhance communication among clinicians, help promote optimal evidence based therapies for our patients? But also, how do we get them access? And I think one of the things you brought up is how do we really target the root causes? And I wonder, Muthu, if you may comment a little bit on the cost of these novel medications that we're talking about that really treat cardiorenal metabolic disease collectively continues to be a large barrier, particularly for those patients that are disproportionately affected by them.
Yeah, it's critically important. And one of the key findings and the final findings of our work was that these effective therapies are, in fact, underutilized, especially at the intersections. And so the more multimorbidity that an individual has, the less well treated they are with effective therapies, not just for one condition, but for multiple conditions. And so this risk treatment paradox, I think, is a really very challenging problem to tackle at a societal and population level, because in our individual silos, in our individual clinical domains, it's entrained in us to be afraid of the intersections. We are often a little bit uncertain about how to manage a patient with heart failure and severe chronic kidney disease. We may be uncertain about a patient with uncontrolled type 2 diabetes, about how to initiate and uptitrate medical therapies. And so this is something that I think we do need to change in terms of our clinical framework. But to your point about access, which is, of course, critically important in broadening and democratizing these therapies, we are getting to a point, hopefully, that these therapies will soon become generic. And so we're right at that juncture. We're seeing that low-cost pharmacies are adopting these therapies. We're seeing also low-cost competitive therapies enter into the market. And so I think market forces are going to be such that we are going to have an improved price point at which we can deliver these therapies. But at the same time, I think that we need renewed efforts at a national governmental level to lobby for improved coverage and improved protection for these therapies.
And as we head into the election year, I think the other thing that we want to think broadly about is how is health insurance and healthcare access also guaranteed for individuals who may not have employer based insurance. And so, as we think about Medicaid expansion and other really federal and state level policies, how do we ensure that this is front and center given how common this is? And this is affecting a huge proportion of the population.
Medicaid has traditionally focused on select segments of the population that have met these criteria, have been at risk populations who have been otherwise vulnerable, sometimes undertreated with usual care pathways. And we can think that patients at these intersections, at CRM intersections, may actually fulfill those very same criteria. They may be vulnerable, at risk, and undertreated, just as we see with, for instance, dialysis populations or patients that face extreme poverty. And so I think that this is something that we need to think about more concretely about, can we actually develop policies tailored towards multimorbidity and CRM intersections?
And how do we really apply that at a societal level where we also think about the upstream social and structural barriers that marginalized populations experience? And that's really a broader question that is relevant to cardiorenal metabolic conditions, but also at a societal level, how do we really start to integrate this to improve the health of all individuals? As we're talking about the findings here, John, what are some limitations of the analysis as you guys were going through this?
One of the key limitations that we continue to come back to was we've alluded to the notion of the need for integrative approaches. And one example of that being guidelines traditionally taking a disease specific approach, and guidelines, of course, being instrumental in directing care to those patients who are highest risk. This is admittedly a bit of an early look as compared to the publication of key trials and guidelines that have begun to adopt this key multimorbidity focused approach. Because we did include a relatively large amount of data between this later period, 2015 to 2020, that the findings remain robust, especially given they're consistent with more recent data. But I think that is one key limitation. The additional limitation is that this is really a subset of the US population that really is featured in NHANES and included in NHANES, specifically those that are non-institutionalized and specifically adults above a given age. And so generalizability may certainly be limited.
You raise some important points, but really continues to highlight the importance of what a growing problem this is. And hopefully, this work will bring increasing awareness on a clinical level as well as on a broader societal level for some of the individual level and population level changes that are needed to help change this tide that is coming of cardiorenal metabolic conditions. Before we close, any final comments or thoughts from either of you?
We'd just like to express gratitude in featuring this work, in highlighting this work, because I think this is a topic that often gets lost at the intersections, but sometimes some of the most interesting findings at scale happen at those intersections, at least from our perspective. And so we're really delighted and honored to be able to publish in JAMA Cardiology.
Well, thank you both so much for your time. It was wonderful to have you both here. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.